So I've nicknamed our next panel, actually, the Bow Tie Brigade, which you will understand momentarily. It's comprised of Dr. Thomas Carpenter. Dr. Carpenter has studied the complications of XLH and worked on therapeutic innovations for this disease for over 30 years. He organized and directs the interdisciplinary pediatric metabolic bone clinic at Yale in collaboration with orthopedics and physical therapy, and has published numerous articles, reviews, and textbook chapters in topics related to this field, and of course has served as the associate editor of the Journal of Bone and Mineral Research. In addition, we'll have Dr. Eric Immel, who we all met yesterday, who is an associate professor of medicine and pediatrics at Indiana University. Dr. Immel is dual board certified in both pediatric endocrinology and adult endocrinology, and he conducts clinical and translational research in rare and common musculoskeletal diseases, including X-linked hypophosphatemia, autosomal dominant hypophosphatemic rickets, and osteoporosis. And then rounding out the bow tires is Dr. Carl Insogna, who we also met yesterday. Dr. Insogna has worked for many years studying hypophosphatemic disorders, specifically X-linked hypophosphatemia and renal stone disease. He was the first individual to show evidence for renal phosphate conservation in patients with XLH, despite the defect in renal tubular phosphate reabsorption. His work in hypophosphatemic disorders has continued uninterrupted over the last 30 years, and he works closely with Dr. Thomas Carpenter of Pediatrics at Yale to explore the natural history of XLH. So please welcome Dr. Carpenter, Dr. Immel, and Dr. Insogna. And we're also going to ask Dr. Jean Deber to come back and join them, even though she's not wearing a bow tie.
I want to thank the panel for allowing me to participate. I find this a very moving day, and it's just remarkable to see everyone here. I thought I would go over a brief presentation that gets at some issues that tend to recur in the clinical context of childhood XLH, address some of the questions that we hear a lot in clinic. That is, what is life like as a child? So being in Baltimore, I thought I might tell you a little bit about how I really got interested in rickets. And I was a little kid, and I used to live in a coastal area not too different from, well, a lot different from Baltimore, but we had crabs. And so you go swimming in the day in the summer, and the crabs were your enemy because they'd find a way to pinch you and everything. And so as a 4 or 5-year-old kid, you'd be constantly avoiding these crabs. And my father came from a long line of people that like to go fishing and stuff. And one of the things that we did at night in the summer was along the bay with a light with these silk mantles. We'd go in ankle-deep water, and we'd catch the crabs when they'd molt. And it was perfect. They came out of their shell. They couldn't move. They had they couldn't bite you. And this is a picture on the left. It's really kind of neat because the old crab comes out of his shell, and he's a lot bigger than the little shell they leave behind. And you're kind of walking along in the water at night, and you're carrying a little peach basket, and the magic of it was that when you pulled the crab out of the water, he stayed soft. And the crab shell was there, and you'd have these little long things that you'd also use if you happen to see a flounder you could get a flounder with, but the flounders weren't around. So you'd just tap the back to see if it was still soft, and it would all happen in about an hour, and then they'd go. And within about an hour, if you weren't on time, they'd start to mineralize. But you can see how important mineralization is, because look at this guy on the right. He can't mineralize. He's got limbs. He doesn't have an exoskeleton, so he is essentially, in my mind, a rachitic crab. And you can see that it's really a disadvantage not to be able to mineralize. And although you guys probably enjoyed eating crabs here, I don't know if you got a soft shell, but if you get a chance to get a soft shell, they're good too. That's kind of what happened after the night. We'd get about 50 of these. We'd get about 50 of these crabs, and we'd clean them, and then we'd go to bed, and we'd get up in the morning, and my mother would fry them like that, and that was pretty cool. But you kind of remember that as a kid because it was really an amazing thing. Mammals, we have an endoskeleton, and we got to mineralize it too. And there's other reasons why the mineralization is to our advantage, and I think you've been hearing about that today. So I kind of wanted to go over what it means to have XLH in early childhood, and a few of the issues that come up is how do you make the diagnosis and what the utility of the genetic testing really is, because you hear more about that with some frequency. Of course, the treatment issues that arise and how we decide how we want to treat, and then how we handle that treatment, how we assess, how we tell whether we have to make dose adjustments and whether we're being effective in the treatment. So with those questions in mind, I thought I would just emphasize what many of you really know so well, and that is, particularly in a family where it's not absolutely clear that this is going on, we base making this diagnosis on a clinical presentation. Children that are not seeing that bow correct by a couple of years of life are suspect for having something like this. It was an interesting story to hear Joanne so movingly tell about being little and being told that she'd grow out of it and, drink some cod liver oil or castor oil or something and you get better. And you have to pay attention if that bowing persists after about 18 months to 2 years, because there is a little bit of normal bowing, but it shouldn't persist. When we see that, we then start doing the laboratory tests, and the things that are critical from that laboratory work that we do to put us in this direction of XLH are that the serum phosphorus has to be low for age. That's another point where the phosphorus levels are different in children than they are in adults, and for many years to meet requirements and to do things inexpensively, the reference range only for adults would get attached to the results of the laboratory work that would come back to the doctor. People would look up in the book how to measure, what to do. They'd measure the phosphorus, they'd see normal, and exclude it incorrectly. So you have to know the age part of that. Then when you see hypophosphatemia, you have to establish that it's renal losses of phosphate, because this disease is not all hypophosphatemia. It's about that kidney problem where you're putting too much out in your urine. A couple of years ago we had these cases referred to us that were diagnosed by some people as hypophosphatemic rickets, but they were acting kind of funny. They didn't respond to the medicines the same way, getting confused, and I was getting calls about how to manage them. And when I reviewed things, the urine data wasn't there, and you need that urine data. And it turns out these patients didn't have hypophosphatemic rickets. The urine wasn't appropriately done, and they were conserving appropriately all their phosphorus, but they had another problem in which a formula didn't lead to appropriate supply of phosphorus. They had a completely different problem, and it needs to be treated in a completely different way. But that becomes the second piece that's important in the diagnosis. And then other forms of rickets will sometimes have a low calcium, often have low vitamin D marker levels, the 25-hydroxy-D. They have high alkaline phosphatase levels, which can be a little bit of a point of distinction because many of the nutritional forms of rickets have really, really high alkaline phosphatase levels in children, whereas the XLH form is only kind of moderately. So it's not a great discriminator, but it can sometimes help us. We've already talked about parathyroid hormone, but we do sample that, and it's interesting, even before we start the therapy, we'll occasionally see these little elevations in PTH early on, and that is useful, but again, in the nutritional forms, it's usually very, very high, kind of like the ALK-Phos. The other marker of the disease, we will sometimes look at this 125, and we'll talk about this in a minute, this other vitamin D metabolite. We'll look at that because it can be high in yet another rare form of hypophosphatemic rickets in which you would not use calcitriol to treat. So we like to see that number too. We have historically not gone to the genetic analysis to make the diagnosis because it's pretty evident from all the things we just talked about in terms of making the diagnosis. With the availability of it, the less expense of it, we're using it more. And there are certain contexts in which I find it particularly helpful. The first of those is if there's something atypical about the family inheritance pattern. Suzanne told you about the peculiarities of X-linked dominant inheritance and how, for instance, in those pedigrees, when we get all who's affected in a family and put it on a family tree, the father-to-son transmission can't happen because the father has to give his son a Y chromosome, not the X, and the X is the mutant sex chromosome. So the father-to-son transmission cannot occur. If we see that, we would look at the genes, because a disorder that Dr. Immel works a lot with, autosomal dominant hypophosphatemic rickets, a different mutation, could be informed by the genetics of that. Another setting in which we would do genetics is when the issue of family planning arises. People want to know really who's got it, what the gene is, what the gene defect is, what are the odds of my passing it on, and the genetics can confirm that and help us, be absolutely sure. There are strange things that will change that, but the odds to be very, very good with prediction. And some of this has raised a number of reproductive questions with newer technologies, and so that will probably result in a lot more of the genetic tests being done. There's another setting when we see the disorder present late in life where it appears to be acquired, and maybe it isn't acquired, and so when it's acquired, we think of the tumor type of disorders like tumor-induced osteomalacia, which you, I'm sure, have heard about. And yet, if you start looking for these tumors and can't find them, you have the puzzle of, well, it's an acquired disease, but we can't find the source of the FGF23, so sometimes a genetic test can find that this was a PEX mutation. When physicians order the genetic tests, it's not just one test that you order. There's a whole bunch of these things, and it's changing constantly as the technology changes. The old tests would do just a sequence analysis of the gene, and I'll show you what that is here in a minute. But newer tests can actually look in places where the places around the gene that don't encode the protein, and this is just to sort of explain that. This bar, the bottom bar represents the gene, and the top bar represents the protein of PHEX. The bottom gene part, a compressed picture of that gene, in each little box is what's called an exon. These little pieces of DNA are what reside on your chromosome, your X chromosome. They together have the DNA base pairs that encode what is the protein, shown in the darker bar, PHEX. The gene is actually a little bigger than this. This just shows you what we call the coding sequence. So this is all the DNA that, if you read it out, it makes the protein. In between these boxes are other intervals of DNA that don't encode the protein, and those are called introns. This gene picture just shows all the exons. But in between these box lines are equally large sizes of segments of DNA. And when you order a gene test, it doesn't look at that at all, but there could be regulatory components, and we have found, particularly at the far end of this protein, regulatory mutations that can cause XLH, just like the ones that are shown here in the coding sequence. In this, different mutations are shown. Some of these are mutations that substitute one of the building blocks of the protein, and some are ones that stop it halfway, and some of them are just big chunks missing, which we call deletions. Both the deletions and the single amino acid substitutions can cause XLH, and they can occur all the way through this protein. And traditionally we've ordered this, and we just get the readout of the sequence. There are patients that we see with XLH that don't show that. And some of these have these, what we think are intronic mutations. Some may be mutations in other genes, and some may be on either side of the coding sequence. And you have to find research labs or other things you have to ask for specifically if you're looking for missing pieces of the big chunks, because there's no abnormal sequence there. So all of these things complicate genetic testing, and we have to be aware of that when we order it, and a negative may not be an absolute negative. A positive is the most helpful test. So regarding treatment, as you know, historically, If you've been in the U.S., we've used calcitriol. Internationally, there's also been another activated vitamin D metabolite called alpha-calcidol combined with phosphate. You know, there are pros and cons to this therapy that we've heard about. Then there's burosumab, which has just come out, and we're identifying pros and cons in the short term, but we want to go out longer to see what the long-term effects of these are. We keep an eye on a variety of things, including the vitamin D stores, which we tend to see some changes in, and we sometimes put patients on some vitamin D in addition to the usual therapies. Even though you have this disease and we have to give phosphorus, you can't ignore calcium, and we want to make sure people also get adequate dietary calcium. And then we have to involve a number of other services, particularly as time progresses. We routinely involve physical therapy. Orthopedics is important, as Joanne has mentioned. Also later in life, ENT problems can arise, and we involve them if necessary. Neurosurgical issues may also arise. So just a word about the vitamin D. This is a slide we use to teach the medical students about the vitamin D pathway, but the important things to know on it are in this box over here is the chemical structure of what we call vitamin D. And it's what you take if you take Drisdol, or if you take vitamin D in a multivitamin, or what they supplement in the milk. It's what you see a lot of people write in the press about, you know, how much we should really be taking, what the requirements are. It gets converted in the liver to the second metabolite, and this is the one that we measure that's the indicator of how much of your vitamin D stores you have. So you'll hear us talk about measuring that vitamin D metabolite. So that's another test. But then that isn't an active metabolite either, even though we measure it all the time. It's this third metabolite, the 125 vitamin D, that is the very same thing as calcitriol. And the defect in XLH is the inability to completely convert that to that. We therefore have to give that as calcitriol, or another closely related molecule called the alpha-calcidol. In doing that, haven't necessarily corrected the issue about making sure you have enough of this too, because there may be other reasons that you have that. So we do have some patients that, despite the fact they're getting the calcitriol, which is the box in red, that we also will make sure their vitamin D stores are okay by making sure that they're getting adequate amounts of that one.
One of the things I wanted to spend some time talking about, as Elizabeth probably said, I see both children and adults in my practice, and so I have an easier time with that transition. I know that a lot of the pediatricians have difficulties with knowing where to send their XLH patients when they become adults, and I know Tom sends them across the way to Carl. I send them across the way to me, which is nice, just in a different building, and that works out pretty well. A couple things I wanted to think about when we're looking at teenagers. We're really thinking about what's happening as people are ending their growth. And why do people stop their growth? The pictures that you see here, on the left is a kid's knee at about 15 months of age, and on the right is the same kid's hand. And this patient has active rickets, the parts of the growth plate. You see sort of this end of the bone, and then this space and this little oval-shaped thing. And that sort of end of the bone before you get to that little oval-shaped part is where the growth plate is. It's the space in between there. And the bone grows from the ends. So you don't grow out of the middle of your bone and just get longer. You grow from these ends. And that's important. In XLH, that part isn't mineralizing very well, and because of that, you get the widening of the growth plate and the softening of the growth plate, and that contributes to the skeletal deformities that happen over time, the bowing and the twisting at times in the bone. As you mature, that space gets smaller. If you look then the left is the same 15-month-old kid, and on the right is a 20-year-old young man that I see with XLH, and so he's done growing, and you no longer have that space between the end of the femur or the thigh bone and before you hit to the knee, and the same space at the beginning of the tibia that you have when you're a little kid. So when you're done growing, all of those are what we call fused, which means there's no more space there and there's no more growth that's going to happen in that bone. That's why we stop growing there. And so one of the things that we always talk about is what are the goals of the medications? And a common misconception among people who don't understand XLH is they think the goal is going to be to normalize the phosphorus. And at least if you're treating with calcitriol and phosphate, that's not the goal. Whereas with burosumab, it actually is possible to normalize the phosphorus level. But we have concerns about the long-term and sometimes short-term risks of trying to normalize the phosphorus if you're using calcitriol and phosphate, because that causes problems with the kidneys and calcium deposits in the kidneys, and it also causes problems with the parathyroid glands when you're using calcitriol and phosphate. So what the goals are really reaching a good final height. Ideally, you'd be trying to reach a normal final height, and we're not very good at that with calcitriol and phosphate. I'll show you a graph here in a second. And one of the complicating things there are that when you go through your teenage years and other kids are going through puberty, they go through these big growth spurts, and you are not speeding up. And so this is an age where the adults may remember when they were still growing as children, that their teenage years were an age when they were getting further behind in many cases in terms of their height compared to their peers. And some of that's a limitation in the magnitude of the growth spurt that kids with XLH have, but some of it's also that they're starting into puberty still much shorter than their peers. Obviously, one of our goals is to have straighter legs. And if somebody's having bone pain, we want to decrease the bone pain and the issues with pseudofractures, or many orthopedic doctors will end up calling them stress fractures. For reasons that only matter to us, they're slightly different, but they don't matter to you. They feel the same. The goal should not be to try to normalize the phosphorus. And dealing with side effects. So how many of you guys like taking a laxative 4 or more times a day? And we certainly heard some people yesterday talking about the problem that was in school. And sometimes being in middle school or high school can be cruel, even if you don't have XLH. And so that, adding on a medical problem can be a big challenge. And then there are some obvious limitations. Now, these aren't teenagers. These two x-rays show 2 of my patients with XLH when they were 8 years of age. Although we commonly think that if you start treatment earlier, that you'll have a better outcome in terms of height. These 2 children sort of flipped that on their head. The one on the right started treated at about 24 months of age, and the one on the left was diagnosed and treated at starting at age 4. They were both short for age when they were diagnosed, but at 8 years of age, one is within the normal range for height at the 10th percentile, and the other one is at what we call -3 standard deviations. -2 or lower is considered short for age, so he was still very short. And also, she had responded very well. She saw some femur bowing, but her tibia are relatively straight, while the patient on the right still has a fair amount of bowing in both the femurs and the lower legs. This is a graph that I simplified so that, because Tom doesn't like to look at the rest of the other lines. It was a conversation we had last week. So I took white boxes and blocked out the rest of the lines and just focused on the one that matters. So the other lines relate to sitting height and arm length and leg length. But this is just the standing height in patients with XLH. And this is on conventional therapy over the past many years. This is a study, I believe, I forget. I think it's out of Germany. It's out of, or a couple of countries in Europe. That dotted red line is -2 standard deviation. So what that is the lower end of normal for height. And you can see at age 2 or 3, if we had 1 year of age, it would be even, you actually would find that up until 1 year of age, the height isn't actually that badly affected, and many patients are in the normal range for height. But starting around 2 to 3 years of age, people with XLH, this is the average value. So the average value is right at the lower end of normal, and as patients get older, you can see that line sort of drifts further away from normal. So even though this is referring to growth and it's going down, it's because we're looking at the comparison to their healthy normal peers. That 0 at the very top, that's the average height for any given age. And so what we see during puberty, which is right when they're seeing that dip. And that dip is less because the patients with XLH getting, growing slower during that time. It's really that their peers are growing faster. And so that sort of magnifies those differences. The final adult height in many, but not all patients ends up being short, even with the best management that we have, even with the best compliance with medication. Obviously, if you're missing lots of doses, that plays into it as well. I wanted to touch on just a couple things. How many people with XLH stopped XLH medication when they were done growing? How many people stopped and then later restarted? How many people restarted because of symptoms that the medicine was hopefully going to fix? How many people stopped and didn't restart? They've just continued as adults and aren't on anything. So some. That was more for, this is our group participation portion. So, all right, now there's a quiz. In XLH adults, is your serum phosphorus normal, higher than children with XLH but still low, or lower than children with XLH? So raise your hand if you think it's normal. Okay, good. That's good for this group. I didn't expect that. So how many of you think your phosphorus is higher than it was in childhood? Wow, you guys just, all right, not very many people call me on that one. And how many think it's lower than in children with XLH? And how many people think this is just a fuzzy question and then just being difficult? All right, good, thank you. This is just a graph of normal serum phosphorus at different ages, and these ages aren't actually grouped. They're grouped in one during the first month after birth, and then during the first year after birth. So it's not a true assessment of linear time as they're growing. But that purple is the normal range for children. At the far side on the right, you can see what the adult normal range is. And you can see there's some overlap in the adult normal range with the pediatric normal range, but the younger you are, the higher your serum phosphorus is supposed to be. And in XLH, this really still mirrors this, that you're low for age in your serum phosphorus, but as you get older, since the appropriate normal serum phosphorus is going down, what you actually see is the adults with XLH have a lower serum phosphorus than, say, the 1-year-old or 4-year-old with XLH. I think one of the important messages here is we don't tend to stop the medication because now you're normal, although I fear that's the message that gets sent to general doctors and to patients is, hey, you're done growing, now you're normal, there's no need for treatment. And the reality is, well, sometimes there's still some need for treatment, and even if we decide that there's not a need to do treatment right now, we're not saying that you're normal. Carl's going to get into some of this a little bit. There's not a general consensus, even among experts in XLH, exactly which patients should be on treatment and which ones maybe should not be on treatment. Now, there are some very severe, and there's one end where patients have a lot of symptoms that are more severe and we think they should generally be treated, and there's on the another end where patients are relatively mild in the way of symptoms, and maybe we have to figure out, does the risk of treatment outweigh the benefits, and in what situation. And it's important to know that in that regard, many of the most debilitating symptoms with XLH as adults, the treatment doesn't, with calcitriol or phosphate, don't fix, and that's frustrating for all of us. Carl may get into some of the risks of calcitriol and phosphate, but these are some of the reasons that we sometimes stop treatment. The laxative effect of the phosphate, obviously, but we see, and many of you have, a fair amount of problems with high calcium due to high PTH, calcium deposits in the kidneys, which can affect kidney function, although the exact incidence is not certain. A lot of the patients get high blood pressure, and occasionally we do see other kinds of ectopic calcification besides just the enthesopathy. I was going to start saying, is anybody taking burosumab? I know there are some people, but how many people are taking it? So several. How many people were in a trial taking burosumab? And how many people it didn't start till after? Okay, so we have a mix of both. What about in teens? How much do we know about burosumab in teens? Very little data so far. Only a handful of patients in the trials that we've done were teenagers. So the age cutoffs for both of the pediatric trials that could have theoretically had some teenagers was age 12, and I think there were only a handful of patients in the trial that's gone on the longest that were close to age 12 at that point. So we actually have very little information on how much benefit is there in terms of growth during teenage years, how much, overall, what's the effect on final height and your adult height when you're done growing, because very few of the patients actually hit that time point, and you can't really draw conclusions based on one or two patients or just a few. And we also have no formal studies to address what is a big question that gets asked a lot, which is, what do you do when they're done growing? Do you continue on burosumab? Do you try stopping for a while, which is similar to what we've done with calcitriol and phosphate? We don't actually have good information. What we probably have are opinions, and the truth is probably somewhere in between various opinions. But I think one of the most important messages is that we need to give you guys, but also the doctors, is that if we're stopping medical treatment that's directed to the hypophosphatemia, focusing on the hypophosphatemia, not on the enthesopathy, the arthritis, and those things, if we're actually, those are different aspects of the disease, but if we're stopping calcitriol or phosphate, or if we end up stopping burosumab and giving people a trial off, it doesn't mean that we're saying that you're, quote, fine or, quote, normal for your phosphorus, and that's an important message for the doctors as well. And it doesn't mean that you might not get some benefit from being on additional treatment. In some cases, it's that we're not certain what the benefit is, but also it's this balancing risks versus benefits. And I think that the real important thing for all of the teenagers is don't disappear, which is what happens when you go off to college and you stop taking medicines and you stop seeing doctors. It's really don't disappear, because patients still need long-term follow-up with an XLH provider, and I think that would make some people restarted on treatment earlier, with earlier recognition that someone's beginning to have bone pain and symptoms related to osteomalacia. But then if somebody is continuing on therapy, they still need pretty frequent monitoring, especially laboratory monitoring. I think the biggest mistake I see among patients who have not been in an XLH center for a while and then are coming back is that they've been getting really high doses of calcitriol and phosphate, trying to normalize the phosphorus, and they've also not been getting good lab monitoring. And sometimes you have to decrease the doses because you're balancing the risk side of things. And then don't ignore pain and pseudo fractures, because I have seen people go along with those for a long time, even though we said come back if you're in, make sure we know. I've seen people go along with those for a long time without getting help. And this is just my pirate skull looking thing. This is actually, for those who are interested, there's a related disorder that Dr. Insonia mentioned briefly on one of his slides called fibrous dysplasia of bone. This is a bone scan looking at uptake in an area of fibrous dysplasia that's near this person's eye, but the authors published this as a pirate sign, so I thought this was nice for October.
Thank you to the organizers for allowing me to participate in this panel. I do not have slides, so you spare your neck. And instead of fumbling with the slide projector, and in view of the fact that, as many of you know, Dr. Carpenter and I are both from Yale University, as is apparent by casual inspection, both of us are wearing bow ties. As most of you know, we have worked together for 30 years, and many of you consider us to be little more than Tweedledee and Tweedledum. And so I feel obliged to use this time that I've saved by not making slides. I feel obliged to make two comments about crabs, since Dr. Carpenter began with crabs. And the first of those is to say to you, although many of you have suffered a great deal with the Rickets as children and then the long-term sequela of the Rickets as children, there's one thing you should be grateful for, which is not that you are a rachitic crab in Mobile, Alabama. The second thing I'd like to point out is I do take a little objection to some of the symbolism for this day. I don't remember how many chakra there really are. I think there's like 6 chakra. I think there's one that's in your soleus plexus. How many? 7. Okay. Well, there's one I think that's in your soleus plexus, and I've been noticing that I feel a little out of sorts right in the center of my body, and I realized that my chakra is out of alignment. And then I realized my sign is Pisces. Okay? This is not my zodiac sign. So I think we be a little more careful what zodiac sign we put on this.
I'm a Cancer, by the way.
Yeah, I know, it's okay for you. All right, so I was asked to address 7 questions. That should take us to about 3 o'clock. Okay.
Not now.
And so I'll start simply by reading the question and then giving you my thoughts. The first of them was, what does it mean to have XLH in adulthood? And I am very grateful that I was at yesterday's symposium, because I had no idea how to answer this question, and you actually provided the answers. So it obviously means different things at different times in your life. As a young adult, it sounds like the principal concerns are, how's this going to impact me having a family and starting a family? How's this going to impact my ability to successfully participate in the job market, get a job, hold a job? And then the other thing I heard yesterday, it was kind of interesting, was a lot of people felt like, and not surprisingly, that they were very physically active in childhood and adolescence, participating in a variety of outdoor activities and sporting activities, and then as you move into adulthood, you begin to wonder whether you're going to be able to continue to jog, you're going to be able to continue to play softball or soccer. So it sounds like those are the kinds of things that maybe come to your mind as you move out of adolescence and into young adulthood. In the middle adult years, it seems like what I heard yesterday was you start to worry about your diminishing physical capabilities and your ability to care for your family. Particularly struck by one of my patients talking about how he was very good at getting things done around the house. He was a handyman around the house, remodeled his kitchen, and you begin to wonder whether those kinds of activities that give meaning to your life are things you're going to be able to continue. And then finally, having gotten a job, a good job, are you going to be able to continue to hold that job? We heard stories yesterday about people who had to change their job because they could no longer meet the physical demands of their job. And related to that, if there's job insecurity, there's concerns about whether you're going to be able to continue to support your family. So those sound like the things that happen in middle life. And then in late adult life, it sounds like the things that become paramount are the increasing restriction in your physical ability and how that restricts the things you can do even on a daily basis, and the kinds of things that you would hope to do or expected to do in later adult years, the so-called golden years, and travel more and be more independent and get out, are now things that suddenly don't seem so feasible to you. So it sounds like and then pain and hearing loss further impair your ability to fully participate in your later adult life. So it sounds like, it's a different answer at different times in your life. And the second question was, do adults with XLH need to be treated? If so, why? And how should it be decided? What are the benefits and risks to treatment in the adult years? And so we've heard a lot about treatment already. So in fact, I'm not going to go through the data on treatment. Dr. Yanderberg did that today, and you heard a lot about calcitriol and phosphorus. So let me just briefly say that, first of all, it's ultimately your decision, right? It's ultimately the patient's decision. From a purely medical point of view, a caregiver may think it seems pretty straightforward whether you should or should not be treated. But for any given patient, there's an individual calculus that you have to make. And that calculus really depends on many things that include the time commitment to taking the medication in terms of the follow-up, the costs of not only the medicine itself, but also the cost of constant medical visits, and your own perception of your illness. Is it really, at this point in your life, a major detriment? Or are you getting by just fine and the added expense and hassle of therapy just doesn't make it? So those are things that I think become your individual decision and factor into your decision about how engaged you want to be with therapies. A number of years ago, every person on this panel participated in a paper that we published with guidelines about how to use conventional therapy. And this was, again, we're talking about BB and AB. That's before burosumab and after burosumab. So BB, before we had burosumab, I guess it was, I don't know, when it was 2005 or so, we published a paper outlining what we thought were reasons to treat adults with X-linked hypophosphatemia. And they were pretty conservative, and Suzanne went over them. Those included significant disabling pain, extant fractures, so a fracture that you have or found on X-ray, severe biochemical abnormalities like a markedly elevated alkaline phosphatase or an elevated PTH, or pending orthopedic surgery. So we based those on the available data at the time that showed that conventional therapy did really have benefit. And I really was struck yesterday by people who reported not having been treated and then starting treatment as adults. We sometimes forget, because, at least I forget, because most of the patients I see have been treated as children and then maybe were off for a little while and come back on. But for adults who have never been treated, I was impressed at how many people talked about really substantial improvement on calcitriol and phosphorus, and I think we heard actually this morning from your patient about that. So It's clear that the therapy does work. Conventional therapy does work, and we did a study a number of years ago that showed that the osteomalacia that I talked about yesterday heals about 50% with conventional therapy, and you do get improvement in pain, and furthermore, you do get accelerated healing of fractures and pseudofractures. But I'll hasten to add that the rate of improvement in healing in fractures and pseudofractures ain't nothing like what you see with burosumab, and I'll come back to that. But as we also know, that this therapy is got lots of hassles associated with it, many of which were already commented on. Now in the burosumab era, I think we're sort of struggling for guidelines in adults. What do we do with adults? So the same criteria, I think, apply. Severe pain, fractures, biochemical abnormalities, pending orthopedic procedures. And let me just give you an anecdote about pending orthopedic procedures. So we had a patient enrolled in our trial who had to have corrective surgery not once but twice on her right leg. On her left leg. She had to have a rod placed because she had bad torsion, and they actually had to fracture the femur to get it realigned correctly. And that healed so much faster the orthopedist couldn't believe it. And then a few months later, the screws that had been put in at the distal end of the leg bone were bothering her so much she couldn't walk. So they had to go in and pull out the rod and take out the screws and put a rod in a different way from the top down. And that healed incredibly fast. And I was just really amazed at how quickly it healed. So fracture healing looks like it's really improved on this drug. In the burosumab era, we are still at a dearth of information. But I have to say that at Yale, we've had at least 40 patients on this drug, some of them for as long as 4.5 years, all of them for at least 18 months or 2 years. And the drug looks pretty safe. In terms of side effects over that intermediate period of time, it looks pretty safe. As I said yesterday, we have to always be very vigilant because no drug, no antibody's ever been proposed to be given from age 2 to 92. But in this intermediate length of time, which is not trivial, we haven't seen biochemical abnormalities or other untoward events that would make us really concerned. So the things that we do see are restless legs, some local injection site reactions. Rarely the serum phosphate gets too high and you have to adjust the dose down. As Dr. Carpenter mentioned, it does look like you need more regular vitamin D supplementation when you're taking this than when you're not taking it. But in terms of calcification of the kidneys, and we looked also at calcification of the heart, we haven't seen that in the double-blind studies. In terms of biochemical changes, like in your blood counts and stuff like that, we haven't seen anything consistent at this point that would make you think that this is going to arise as a problem. Doesn't mean that that won't happen in the future. And as Suzanne pointed out, and it's very important to point out that that double-blind study is critically important. That design is critically important because her slides showed you that there was an improvement in pain and stiffness and physical function, and you saw those beautiful lines going down, down, down. But around each one of those dots on that line, there's a range of responses, right? And so it's not magic. Not everybody gets those kinds of responses. On average, people got those responses. And the fact that it was double-blind meant that there was no bias on anybody's side. And the reason I'm making a point of that is that it gives you more confidence that when someone begins a drug like burosumab, and maybe they don't have these symptoms, improvements that you're expecting, they could be in that range where people just don't get as good a response. Or it could be that it's going to take a little longer to see that response. And so the fact that we see the slope of that curve and we know the time course over which it occurs, the fact that we know that not everybody responds, takes some of the mystery out of it. It allows us to be confident that this drug on average has effects. It also allows us to recognize that not everybody gets the same dramatic response. But again, it looks like a lot of the functional endpoints that you talked about a lot yesterday, pain, stiffness, physical function, do improve on average with this drug. what does that mean then now? For patients who don't meet those criteria that I just talked about, that don't have pain, fractures, gross biochemical abnormalities. I don't think I have an answer. I doubt anyone on the panel has an answer that's based on data. So we are in an era where we're kind of flying by the seat of our pants. And so I'll tell you what I do, and you should take it with an enormous grain of salt, because I have, just a handful of patients who were not in the trial who are now approaching me about therapy. For the patients who are on the trial, interestingly, most of those patients are still staying on the drug. So anybody who has biochemical evidence of osteomalacia with an elevated bone-specific alkaline phosphatase, radiographic evidence of a fracture, or has a history of what sounds like an insufficiency fracture not related to trauma, I'm tending to recommend therapy. I'm on the fence now about whether we should be more aggressive about screening people with x-rays when they come and they are otherwise asymptomatic. I think that's a question, and we were talking about that, whether we should actually be imaging people's spine, doing MRIs, and I don't know the answer to that, to look harder for other evidence of early disease in patients. And again, this is just me, if patients' serum phosphates are chronically running really low, like under 1.5 chronically, it's lowering my threshold for considering intervening. Again, these are otherwise patients who are looking pretty well. And particularly in patients who have a bad family history, in patients whose parents or mother or affected individuals wind up having a lot of enthesopathy, that lowers my threshold. And why do I do that? Because I'm hoping, like everyone else, that this drug prevents these long-term complications. And that's the million-dollar question. And it'll be somebody else standing up here telling you the answer when we finally know it. And then patients who are on conventional therapy and are doing well on conventional therapy and tolerate it well and look biochemically well, I think they should just stay on the therapy. One thing that is pretty clear, and somebody mentioned it yesterday, is that obviously for this to be a tractable therapy in the long term, although the people at Ultragenics have done a really good job of trying to make the drug accessible to people, we really need to eventually move to self-injection. It's just not tenable to have a nurse coming into your home every day or having to go to a facility, not every day, every month. It's just not tenable. So eventually we're going to have to move to self-injection if we're really going to talk about this long term. I'll collect my $50 later for that. And then, as Eric said, it's really the toughest group are the 18 to 24-year-olds. The group where the person I mentioned yesterday, the 19-year-old supposed to go off to college. What are we going to do with them? And I don't think we really have an answer. I think the things I talked about are the kinds of things I'm using in those individuals to decide whether to begin treatment or not. So the third question was kidney issues, GFR guidelines for Burosumab. Why is it not indicated for patients with reduced renal function, even if the drug presumably does not cause a risk to kidneys? Well, the answer is pretty straightforward. The kidney, as you know, is how you excrete phosphate. And the problem is that when you give this drug to someone with kidney disease, the concern is that the combination of the drug and the inability of the kidney to normally excrete phosphate is going to wind up making your blood phosphate go too high. And in the setting of kidney disease, a rising serum phosphate combined with the fact that Burosumab normally allows you to make more 125, but in kidney disease you may not be able to do that, may lead to problems with stimulating your parathyroids. And then what everybody worries about in kidney disease is calcification in other tissues, like your blood vessels, and like your heart, but mostly blood vessels. So there are no guidelines about at what level of renal insufficiency you should not consider it, but we're very skittish when people's renal function falls below 60 and certainly below 50. That means 50 mLs a minute to consider this drug for that reason. The fourth question was mobility, loss of mobility, suggestions for maintaining mobility. So there are no magic answers here. I think, stretching exercises, gentle yoga, someone said Pilates works for them. I think you need to try these things. You have to recognize that if you've got enthesopathy, there's no amount of stretching that's going to improve the range of motion of your joints. And a lot of people just find it too painful. But if you're in your 20s and 30s and you have good joint mobility, then there's no reason not to continue doing these exercises if you find them helpful. I don't think there's any particular exercise that I especially endorse, except for maybe Tai Chi. I think Tai Chi is an incredibly good exercise because it improves balance and keeps you mobile. The problem with Tai Chi, as I've learned, is that it's not just an exercise, it's kind of a way of life. So you really have to make a big commitment to Tai Chi. It's not easy. Pain is the fifth question, how to manage pain. Well, as was pointed out a number of times yesterday, this is a huge problem now. Because of the opioid crisis, there's been a crackdown on the use of opioids, and a lot of patients really rely on opioids to maintain their pain control. Now, yesterday, it looked like there was only about 35% of patients who were actually using opioids. In my practice, a lot of patients use opioids. I don't have an answer. This is a huge problem because I have lots of patients who are screaming mad because their physicians won't prescribe them opioids, and they're not allowed to get the number of doses that they need, that they feel they need to maintain pain control. What I've been doing is working with a pain clinic in New Haven who I've sort of educated to this problem, and they have worked out ways to try and control this, but I don't have a good answer for that. I also think that there is a pushback among pain specialists about how effective long-term opiates are in pain control. There's a whole theory that long-term opioids basically have the opposite effect of pain control. So they don't have good alternatives, though, for that hypothesis. So unfortunately, we're really stuck in the middle in terms of patients on opioids. I don't have a good suggestion. I think I'm turning to pain management specialists and trying to educate them about the disease and trying to see what they can do in terms of helping within the constraints of these increasingly restrictive federal guidelines. And loss of hearing is the sixth question, and I think this fits into the bucket of enthesopathy. If we can prevent enthesopathy, presumably we'll prevent the same kind of osteomolasic changes that occur in the bones of the middle ear, and maybe prevent the changes that occur in the cochlea. I just don't think we have enough knowledge about the pathogenesis of those, except maybe the middle ear bones, where presumably the same problem of osteomalacia occurs, to know that whether that's going to occur. And the final question was reproductive issues. So there's an easy answer and then a not so easy answer. So before burosumab, it was a pretty easy answer. In pregnancy, the placenta makes damn sure that that growing baby gets what it needs. It really doesn't matter how bad the mother's nutrition is. They've done studies in India where mothers have been grossly calcium deficient. The fetus still gets enough calcium. In XLH, the baby comes out pretty normal in terms of skeletal metabolism. So the fetus gets the phosphate it needs. So part of that is because the placenta makes 125 dihydroxyvitamin D. So the mother kind of treats herself. Her vitamin D levels in a pregnant patient with XLH, I just have one now, their 125 levels normally are like 25 or 30, hers is 90. So she's getting lots of 125, so she doesn't need calcitriol, she's sort of making her own calcitriol, and that helps her raise her serum phosphate. If their serum phosphate is still kind of low, you can give them phosphate. If they've been on calcitriol and phosphate, you can continue it and just drop the calcitriol. If they're not on therapy and their phosphate's not that bad, you probably don't need to do anything. So it was not a big deal, pregnant women with before burosumab. Now, after burosumab, we have a problem. I mean, we're going to send out into the world lots of women in their reproductive years who are going to be on burosumab. Burosumab hangs around for a long time in the circulation. We give it every month, but I can tell you that when you do certain biochemical tests, you can see that it hangs around for a while. We have no idea whether it's safe or not in pregnancy. I have a feeling we're going to wind up finding out because people aren't going to really be that careful about this or get pregnant while they're taking it and not really recognize that. I mean, I think by the book, the answer is probably going to be if you're anticipating starting a family, you need to talk to your physician and decide whether you really should continue burosumab, knowing that we don't know if it has effects on the fetus. And perhaps the more conservative approach would be to stop it and try conventional therapy. I have no idea, but I suspect human beings, what they are, we're going to wind up having a lot of people who wind up getting pregnant and still taking burosumab, at least initially. Then finally, the issue in reproduction is one of the issues that Dr. Carpenter made brief allusion to, which is whether more sophisticated reproductive technologies are going to come to bear in this disease. I think I'll stop there, though.
We're going to open it up for questions. I do want to add one thing to Dr. Ansonia's discussion about management, medical management during pregnancy, is make sure you're monitored closely. I think because of this endogenous increase in 125D, or basically your body's making more calcitriol, that there is some risk in some patients of getting a higher calcium. I did have one patient who was continuing on relatively small doses, but she had a transient worsening of her kidney function, and so I tend to monitor those patients every month with labs just to keep track of that.
I see a nephrologist. I've seen him for maybe 5 years now. Knowing very little about XLH, I never really discussed that with him, and I've never tied that together with my endocrinologist, which is what I will be doing as soon as I go back. But about 6 months ago, he told me that he wanted to change from the calcitriol to a new drug, which he said was more effective. I haven't heard it mentioned at all here today. It's called Rayaldee. Anyone familiar with that?
I have a suspicion this is a different form of active vitamin D that none of us end up using, and that's the nephrologists do use some other forms of active vitamin D that are like calcitriol, and that may be what he's thinking. It's probably always bad news if you have a panel of experts up here who have never heard of a given drug.
It's calcifidiol.
Oh, okay.
25-hydroxy.
Right, so that would not be good.
I see him on Tuesday, and we'll be discussing this.
So what we were just talking about, so we did figure out it's the 25-hydroxy vitamin D, it's that middle one, and you guys don't convert it to the active form appropriately. So that would be not better than calcitriol for an XLH person.
My endocrinologist is really concerned about my magnesium levels. Thinks that has to do with my hypophosphatemia. Is that considered relative?
You mean that they're low?
Yeah.
Do you have any GI issues?
No.
Are you taking phosphorus?
Yeah, I am taking.
But it doesn't cause diarrhea or anything?
No,
like
not
that?
for me. Mm-mm.
There are several reasons that you can have a low magnesium. If it's very low, then it may imply there's a separate disorder that needs to be investigated. If it's sort of borderline low, these can sometimes be explained by protein levels running a little bit low. The other times we see it low is in a kind of an opposite context of the parathyroid problems that we see in XLH, where the parathyroid level is high. But sometimes when the parathyroid hormone level is low, we see the magnesiums run a little bit low. If they're on the borderline, and if a corrected, sometimes you've heard us talk about how we have to correct the serum calcium for the protein concentration. You sometimes have to do that for magnesium too, because in large part it's protein bound. So it would be useful to do that exercise to make sure that the active free magnesium in the blood is normal or close to normal. Has there been any concern about symptoms of low blood magnesium, which are usually sometimes things like tetany, also be jitteriness and
Jitteriness. Yeah,
something
I do.
like that?
I have a lot of jitteriness. I can't drink caffeine.
It should be further investigated, but something independent of XLH.
Okay, thank you.
I actually have two questions, but they're related. My question is, do teens have the same degree of pain as adults, and how are they managed? And do you use CBD oil, or are they used over-the-counter or narcotics to treat their pain?
I won't speak for the adults, but the teens tend to have, I would say, a little bit more pain than the younger children, but it's not what I've tended to encounter in most of the adults. I've not seen pain in the teenage age group at the level that would really require narcotic control, but
Yeah. The ones I've seen need more in the way of pain medication were usually people who had stopped therapy and they were having active pseudofractures. So actually, I didn't point it out, but the 20-year-old that I know he's not a teen anymore, but the 20-year-old that I was showing for my example of closed growth plates had a lot of leg pain from pseudofractures and was on some narcotics. But I think most of the teens that I've managed haven't reported large amounts of pain. Some of them occasionally are having pain after long activities or after sports, but a lot of them were just dealing with it with anti-inflammatory medications.
What effect, I know how XLH is currently affecting me as I'm going through puberty, but because I'm transgender, what's going to happen as I'm still on burosumab as I start to transition? Is there any crossing effect or anything that would affect it in particular, especially if I'm going through development a second time?
Not that I can come up with a biological reason for that. I don't think that it would alter the effect of burosumab.
Okay, thanks for soothing that sort of concern.
Hi, I just wanted to say that I didn't develop pain. I've been on treatment my whole life. Didn't develop pain until probably in my 50s, and started with all the anti-inflammatories, and then the past 5 years resorted to opioids. And it just seemed like they would stop working, and the doctor just wanted to increase them, and then increase them. So I did try the CBD oil, and if you knew me, that's not something I ever did or would have ever thought of advocating, but it definitely helped. I would say it took away more than 50% of the aching pain. Now my joints being older, and I'm 67, but my joints hurt more from the arthritis pain, I think. But even that, one day at work, I couldn't even open an envelope with my fingers, and I couldn't hold a doorknob to open it, a round doorknob. And after using the CBD oil, I picked up the same envelope because I couldn't believe the difference, and I was able to do those activities that, an hour before I couldn't do. And there's really you don't feel any effect. It's just just like a sigh of relief that pain is gone. And I said, I have more energy, but I don't know whether it's because I have less pain or whether CBD oil gives you more energy, but I definitely feel better, using the drops.
The panel up here was wanting some clarification on, given our apparent lack of experience with CBD oil, how you take it. Just a few drops. I mean, there's different forms of it, either a balm that you can rub on your skin, or there are drops that you can use, just 2 or 3 drops under your tongue. Right.
A few times.
So which one were you doing, the topical or the
drops?
The drops, okay.
Right. But I'm saying it definitely, lasts a long time, and the relief is amazing. And I'm not on any pain medication now. No opioids. Mm-hmm. And there's a lot of side effects from the opioids that were very difficult to live with. And just the fact that, and my older son is severely disabled, like my younger son here, and he's on fentanyl and opioids, and he's still in chronic, excruciating pain daily.
I have a question about early to mid-adulthood and your thoughts, knowing that none of you are orthopedic surgeons, but your thoughts on joint replacements and whether it makes sense to just keep having corrective hip surgeries or go in for a joint replacement knowing that you'd probably need another one.
She was looking right at me when she asked that question. Funny, because she knows already the answer is, who knows for sure. I mean, the thing what do we know? We do know that most joint replacements work just fine in XLH even before burosumab. I can't imagine they work even better after burosumab in terms of the healing of the site where the way you do hip replacements now, it's either a partial or total hip replacement. And with a partial, they basically just will replace the ball of the hip joint and leave the socket in place. And in the total hip replacement, they'll replace both the socket and the ball. And the socket basically gets pressed into the bone. In the old days, they would drill it in. Now they pretty much just press it up in there with a glue. And so the part that really needs to heal is the ball down into the shaft of the femur. And that, if anything, should heal well. The question is the duration of the prosthesis. How long is it going to last? They last 25 years. Probably that's the outer limit in terms of their use ability. So I think the answer really still remains how debilitating you are by it. I mean, how in the next couple of years, how much do you envision this impacting the quality of your life? I think that if it's really impacting your life adversely, there's enough data out there, and certainly in 30 and 40-year-olds who have had traumatic injuries or sports-related injuries to their hip, that have had a hip replaced and gone back to being just as active as they were before. As you probably know, there's now two approaches. There's a posterior approach and an anterior approach. The anterior approach gets you better range of motion. It's associated with a slightly higher risk of infection, slightly greater chance for damaging some of the nerves in the thigh, but generally in experienced hands it goes well. Recovery's a little quicker. So I tend, not necessarily in XLH, but in general in patients that I see, I tend to recommend the anterior approach for that reason. And certainly in young people, that would be what I would recommend. I don't think there's any proscription against doing it. I just think you have to realize that it's a cost-benefit thing. Yeah, if you're 30 and it's going to last 25 years, chances are you're going to wind up with at least a revision at some point.
Just a couple quick questions. How are you tested for enthesiopathy? I don't think I've ever been tested for that.
So a lot of people have a lot of enthesopathy and don't know it because it's not what you end up thinking of. But if somebody's ever, it's just mostly just plain x-rays. But if someone's talked about bone spurs, or if you have evidence of spinal stenosis and you have XLH, these are all things that we're lumping under categories of enthesopathy that leads to, it sort of evolves into bone spurs over time.
Mine's my neck and my shoulders, and I've been massage, chiropractor, anything to relieve it, but I've never been tested for.
So it's something that you may have actually been tested for. They don't always call it even on x-rays from different radiology reports.
And I think it's important to know we all get that, but at a later age. You know, we'll all get it 7, 8 decades out. It's just advanced and accelerated in XLH. And in a series we did, everybody had it by the time they were 30. So it's probably there, you know, without even doing a test.
Okay, and my next question, I've heard a lot of this yesterday and today about fatigue, but what's the relationship between the fatigue and the XLH?
Really interesting question, and I was really struck yesterday that that was like the second or the most common complaint on that survey. It was like 24% versus 22% for pain. So that was really striking. And anecdotally, yeah, we saw that in the burosumab trial. People, particularly people who were really active, really noticed that they had more energy. And, you know, it was really always hard to quantify what's going on there. I think one of the things that I'm biased to believe is that it improves muscle function. You know, there's some preclinical data that suggests that as you raise the serum phosphate, muscle function, in terms of actually measuring energy generation in muscle, improves. And so this drug normalizes serum phosphate, and that may in some way improve muscle function. I mean, there's some, as I said, animal data and very limited human data that suggests that's the case. But people are less stiff, and, you know, the classic thing is the classic thing that used to happen is you're really busy one day, you're either playing sports or shopping or doing whatever, and the next day you're just miserable because you're really stiff. You don't hear that as much in people on burosumab. So I think muscle recovery, muscle function may be part of the reason, but the sensation of fatigue, the sensation of that you've just got more energy, I'm not sure where that exactly is coming from.
I have a question about teenagers that, growing, and they decide to don't get treated anymore, or at least until they need to get treated. The question is when. You know, we hear the situation that if you have fractures, if you have a lot of pain, but that is already like post-treatment. You're already trying to fix a problem that has already started. How often a teenager that decides to stop any treatment should be at least checking how their bones or what kind of things they can do to really start looking at the beginning before the fracture really happens?
I've taken a strategy to reduce but not stop therapy and keep the monitoring going over the college years before I turn him over to Dr. I over here. The interesting thing I'm using as some speculative data to inform me on that is that even though the growth plates close and we're not worried about the rickets, the bone in the late teens and early 20s is still really active with a lot of turnover. It's almost, even though you don't have a growth plate, the bone is still much like a child's bone. So even though, because you're not making new bone, we think the demands for the mineral are less, so we in turn drop the dosing of phosphate a little bit after growth. I've kept them on somewhat low doses through these years with monitoring, and if everything really is perfect, as I start to wean down the dose, I'll stop, but still continue to monitor. But I have to say that at a certain level, I'll start seeing alkaline phosphatase start rising again, and so it's been a minority of patients that have stopped entirely in that little window of time.
But I also think that if somebody is, whether they're a late teen or a college student, I think they should still be checking in with their XLH doctor once a year, because maybe on discussion they might find that they are having symptoms that would just, that between the patient and the doctor, like Dr. Insonia said, that you've got to sort of balance everything together for every individual patient, and that might be something that would lead towards more treatment. The people I see people disappear for long periods of time and take, a couple of years after they actually start having, significant symptoms to reconnect. And so I think trying to make sure that they know to come back and have like a yearly follow-up, even if they're not on medicines.
So you mentioned the ALK-Phos is one of the key markers that you will be looking for. How often the tests, would you recommend them that they do every 3 months like they were doing the kids, every 6, every year?
I've tended to go every 6 months and, try to work it around. Usually the children are off at college or away, and so I try to work a summer and a winter visit. And, it's not perfect timing because of those calendars, but I usually end up doing it twice a year in there. And as they get older, the other thing I've started doing also on the basis of what Dr. Insonia's been seeing in adults is this new test, the bone-specific alkaline phosphatase, is a little more sensitive in that after childhood ends. I used to sort of live with, the ALK-Phos is normalized, but in more recently doing the bone-specific alkaline phosphatase, I'm seeing some of those patients are actually high in that, and I'm tending to weigh that more in these decisions.
Our son Jim has tumor-induced XLH, and there was a time not so long ago when he stepped off the curb and fractured his leg. So I just want to make a quick comment. Somebody made reference to something yesterday, and I took a look, and when I hear the word neurological and pain in the same sentence, I tend to look into it a little deeper. So I just wanted to make a comment that Roy brought to our attention yesterday, and I don't know if you've ever heard of this. It's a neurotherapy called accelerated recovery performance that treats soft tissue neurologically. If you're suffering from chronic pain, it may assist in that. I'm not here to promote anybody's product. I'm just here to tell everybody you can't ask too many questions and you can't ask stupid questions. We're here to network with each other. So if I look into this for Jim's joint pain and things, as an old person, I may be able to share the same process.
Thanks for your comment. I think that there's several origins of pain and tumor-induced osteomalacia. One is muscle pain and muscle fatigue and bone pain that often is accompanying the bones being unmineralized, the very low phosphorus levels. And many times that will respond to repletion with phosphorus and calcitriol. I know that hearing his story yesterday, he has a skull-based lesion, which may be impinging then on the nerves of the spinal cord, and that may be causing a different type of pain. So I guess I would just say is just try to sort out what type of pain we're talking about. Is there any room to treat the low phosphorus more aggressively to help the muscle pain and the bone pain, or is this a different type of pain that's arising from the impingement of the nerves near the skull.
I have a 3-year-old granddaughter that has XLH. Does the burosumab work for that age?
It's approved, you said 3 years old?
3 years old.
Yeah, so it's approved from 1 year of age and up.
And what would it help?
Things it helps with in that age are going to be similar to the things that it helps with in the older children, which is going to be to help with growth and with improving the rickets, improving the bowing deformities. I think that's mainly it.
Her legs are really bowed. That will help the bowing straighten out?
Mm-hmm.
Yeah.
Yeah, but especially if this is, sort of at the beginning of treatment. I think that even with conventional therapy with calcitriol and phosphate, I think we see a larger magnitude of improvement in the bowing during those first few years on treatment than we see necessarily after they've been on treatment for a while.
Okay.
But that's not to say that it couldn't continue to improve. But I think that if they're just starting on it and somebody's talking about surgery, I might suggest maybe giving it a little bit of a chance first.
And did I hear you say that when you take the burosumab that it's good to take the 125 or?
No, you absolutely do not take phosphate and calcitriol at the same time as burosumab. That's a good, important message, because if your doctor doesn't do a lot of XLH, they might miss that. So remember, after you take burosumab, your body makes its own calcitriol, and especially early on, after the first few doses, especially, you get a big spike in your own calcitriol level in your body that starts about 3 days after the injection and lasts, it's sort of in between 3 and 14 days you have this big spike. Later doses, after you get out to being on treatment a year or more, that spike isn't as large, and we have some theoretical reasons why maybe that is, but that's really important. You wouldn't really want to be taking calcitriol and phosphate on top of that. That would increase the risk of driving your phosphorus too high or possibly driving your calcium too high.
We don't have any data on children from the studies on children that were started before age 1, and most of the data that led to the approval came from an analysis of children that were treated that were started treatment between the ages of 5 and 12. The data in the 1 to 5 study after the first 64 weeks were very good, and in fact maybe even showed more dramatic reductions in the severity of the rickets by radiographic scores than in the 5 to 12-year-old group. So I think the maxim that we've sort of lived by with the standard therapy of starting any therapy earlier than later is probably going to be better. It can be transferred to the burosumab story too, with the caveat that it hasn't been studied in children less than 1. There's, I think, some plans to do that over the next couple of years, though.
My daughter just started Crysvita about, a month ago on her second dose. And her doctor, this is the first case that she's been treating. So I heard you guys have like a XLH center and all this, but we're in California, and is there any place that we can take her, like to go see you guys, the experts? How can we get her to get into your
I can think of at least 2 places in California that are part of our sort of have been involved in the research studies. One is at UCSF. In nephrology with Tony Pertale and Farzana Perwad, and the other I think is at the David Geffen School of Medicine in Children's Hospital of LA. But there is an XLH person that's part of our that's been affiliated with these studies in LA as well. Those are the two I know off the top of my head.
And you said they're in the LA, in like USC, like the medical center, like over there? Or?
One is in the CHLA, Children's Hospital LA. It's one of them, and the other is at UCSF in San Francisco.
And the doctor that's treating her is out of Fontana. Is there somewhere we could recommend for her to go, like look at guidelines of what she should be monitoring, maybe even closer, or monitoring the correct things for her? Like the correct levels of phosphate, calcium, all that type of stuff.
So if they're monitoring burosumab, I was about to say, just look up our names at this paper that he alluded to from 2011, but that was pre-burosumab. And so the best thing she could do is probably look, you can get information, some through Ultragenics will have some information for her. That's the company that's producing burosumab or Crysvita. They could access the published papers. So in the children, yeah. So so that was one of the questions: is how are we monitoring things? And I think one of the important things is during the clinical trials, we did have some provisions for increasing the doses in children, especially, partly because the first study that we published in children, we didn't know what the right dose was, and so we were making dose increases. Started very low, and we're increasing doses over time. And Tom led that study. I have heard from a few people who weren't on the study, and they said, oh, well, we've increased our dose every month, and that's probably not what you should do. You should probably give it a few months before you increase the dose, based on, and based largely on the serum phosphorus levels to make sure they're getting sort of into the normal range, but you don't want to be running them too high.
There's also a published guide that Ultragenics Crysvita materials include that have a number of specifics about how much to change, when to monitor. She probably has access to that, but we should talk offline later, and if not, we can make sure, maybe even with representatives here, that information can be provided if it's not already in her hands. But everyone that's been prescribing it has had access to these in one form or not. There may be some incomplete penetrance of that, but we'll be happy to make sure that gets distributed.
Maybe it's what I need as some advice. And I have some insight on knee replacements because I've had 3. And what happened is when I had to have my second one on the one leg, my bone disappeared. From one year to the next, when I had my x-rays, there was almost nothing holding that knee replacement in there, just maybe not even an 1/8 of an inch. And so they had to take that out and redo it. Shattered my tibia, but that's okay now. All I have is lots of cute little bow ties of wire all over. But what I noticed was, I don't know if that's normal. Soon after I had that second knee replacement, I started to get the symptoms of parathyroidism. Since I have no doctor that knows anything about it, I am self-diagnosed with things, so I finally figured out that I had the parathyroid problem. Could not find a doctor anywhere near me or going clear to, Salt Lake and everything. Didn't know what was going on. My question is this: they took 2 tumors off of they took 2 of my parathyroid glands out because they had large tumors. Immediately, my brain fog left. I mean, I woke up and said, oh, hey, you got me back here. So that helped. But was that the reason? Because they had no idea, the orthopedic doctors that worked on me, because they don't know anything about XLH. Is that the parathyroid problem what caused my bone to disappear?
Well, one question I had is, were you on calcitriol and phosphate during that time after that first surgery?
I want to clarify that, because I might be the only person I'm 71 years old, and I have been on it since 1982, and I have not missed a dose. So,
That's
and
impressive.
I do have fairly good quality of life. Not perfect, but I have a fairly good quality of life. And the doctor was giving it to my son, and I asked her, I said, how about me? Is that going to help me? And she said, well, I don't know, try it. And so I want you to know, if you need me, I have been taking it that long.
So I just have a couple comments, and I'll be happy for the panel to weigh in. Sometimes when you get a hip replacement or a prosthesis, there could be osteolysis. It's called periprosthetic osteolysis, meaning that the bone is broken down. And that can happen in people with normal bones. So, just because you have XLH doesn't mean that you can't have something true and unrelated. So that may have you may have had osteolysis, a periprosthetic osteolysis, which is a big problem. I think your hyperparathyroidism probably didn't help things, because it also can break down bone and cause osteolysis. So it may have been 2 things happening at once that made it more severe and made your prosthetic loose and then have to be redone.
Yeah, I think what Suzanne says is exactly right. The other thing you said is it sort of appeared after the surgery. Probably what happened was you became less mobile, and when you are less mobile, sort of that helps make the serum calcium go up. So I bet you had hyperpara before. A combination of that and bad bone made it worse. you probably had osteolysis as a consequence of that. Yeah, in patients with XLH, if they have bad hyperpara, I usually try to get that under control before they have a joint replacement.
I have a question about high blood pressure and how it's related to people with XLH.
You're venturing into the twilight zone, but I do think there is a link. I don't think it's perfect, but there's a link with the hyperpara aspect. There are series that have been reported in which blood pressure and PTH levels have been closely associated with each other in patients with XLH. So there's an association. What the cause and effect is still a little mysterious. There's another whole literature that's very old that parathyroid hormone may actually play a role in this. But then the other overlying feature with XLH is if you've been exposed to the therapies for long, long periods of time, and if the nephrocalcinosis if it's been at a level where there's been soft tissue calcification and particularly progressive nephrocalcinosis, then there is some risk of renal function being impaired, although it's pretty low. But that too then could contribute to that parathyroid effect and maybe have effects on blood pressure.
I mean, the other point is that so far there doesn't look like there's a signal for hypertension with burosumab, meaning that it doesn't look like it makes it worse.
I had a question about a drug that my doctor's giving me, my nephrologist actually, and my kidney function has dropped dramatically. I mean, it was 59 for probably at least 15 years, and that was because of this high-dose vitamin D back in the 60s. But then I started Sensipar, and it dropped like a rock, and now it's about 30 milliliters per minute. But he's also giving me chlorothalidone. He wants to keep, he claims that that will keep some of the calcium out of the kidney and also allows more of the phosphate into the kidney, or back into the bloodstream, I guess, more reabsorbed. Which it seems to be, in a sense, because my phosphorus is low normal now, but that could be because of the kidneys not filtering it, but, you know, with the renal failure. But my urine calcium is quite normal, but my serum calcium is elevated at about 10.5 now, 10.4. But is chlorothalidone okay in XLH, or is he maybe doing something that maybe for some reason isn't advised, like the burosumab causes, you know, the other?
Yeah, I'm not sure what the chlorothalidone is being used for exactly in that circumstance.
He claims that maybe it'll keep me from calcifying the kidneys.
Yeah.
We don't have proof of that.
I mean, it doesn't, if you're hypercalciuric, if you have a high urinary calcium.
It's not.
Yeah, I don't think it prevents nephrocalcinosis, because where it acts is not where the calcium actually accumulates in nephrocalcinosis. So as far as I can reason, and I'll be interested what other people say, you wouldn't give it to prevent nephrocalcinosis. It's not going to prevent the calcium from getting to the parts of the kidney where the calcification occurs in nephrocalcinosis. We use thiazides, which is what chlorothalidone is, in patients who have high urinary calcium and kidney stones. It's good for that.
Yeah, I think he's a big deal in kidney stones. I think
right, I just don't see that it's going to impact nephrocalcinosis that I can think of directly.
Okay, but it's not contraindicated, or?
No, I mean, if he's using it for hypertension, it's a good drug for hypertension.
Yeah.
Okay, thank you. I guess I just worry that, you know, it's a diuretic, and so diuretics cause dehydration, and that could then compromise kidney function. So to me, I don't see a real clear indication to use it. There might be an indication not to use it. So I would maybe stop it and see what your kidney function does.
And I think the other thing to worry about is I have occasionally seen people who already have high calciums from hyperparathyroidism, and people are starting a thiazide in an attempt to lower the urinary calcium, but you're basically doing that by preventing the body from getting rid of some of the calcium out of the blood that it's trying to get rid of.
We have the information about the new drug, the Crysvita, or Crysvita, available to our doctors, and my endocrinologist has read that. Is there a place where they can go just about general XLH? Because I've been on the KFOS and calcitrol for probably 15 years, and I've never had a urine sample taken. They don't know what tests to take. They don't know just general information.
So the answer is yeah. There are several publications, many of which we've written, that are accessible to the general endocrinologist and primary endocrinologist that provide some guidance in that regard that might be helpful.
Where do you find those?
Well, some of them you can access on like PubMed Central. Actually, you could access.
I was getting ready for the answers to my questions in the afternoon, but one of the things that was, I scrolled through the XLH network website, and that needs to have a little updating and a little more focus on the thing. There's too many references there. You just got to put a couple of key references there. And the other one that basically every physician uses these days is a thing called UpToDate. And this guy here partly wrote that section. It's really good. It's really good. And everybody has access to UpToDate.
So you would go to UpToDate and
UpToDate
and
gives you,
XLH, and then look up.
UpToDate, you look up XLH, and it's a really good, very current summary. It includes stuff about burosumab. And your organization's website needs a little bit more focus in terms of, it has an exhaustive reference list, but as a physician, it's a little overwhelming. I think you need to put up at the top the key few references that people can get to.
Is there any increased risk to pregnancy in your 30s with the XLH? I'm asking this for my daughter. I'm not in my 30s.
Somebody was pointing out also in relation to burosumab and things to monitor, Ultragenics has put out a really good educational website about XLH and a lot of aspects to XLH, and all they have to have is access to the internet to get that. UpToDate is actually a service that people pay for, and so it depends on if it's a private practice, they might have paid for it. If they're part of an academic institution, often they have access to it. Again, there's a system called PubMed that there are certain things that are published in PubMed that any citizen in the United States can just access. There's a few steps once you click on it, but you can access some articles directly and in their entirety through that. In relation to pregnancy in your 30s, I don't know that the risks of pregnancy in your 30s in XLH are that different than, compared to pregnancy in your 20s with XLH. I think that's going to be similar to pregnancy in the general population in your 20s versus in your 30s. Unfortunately, this is going to break everyone's heart that when you hit 35, they refer to it as advanced maternal age, and I'm very sorry. I think it's an unfortunate term.
I had a question about your experience with burosumab and any advanced or regression in spinal stenosis.
There is no data on regression of any form of enthesopathy after giving burosumab. My personal thought is that it's probably not going to reverse those calcifications that are already there, just because of the nature of what they look like if you were to look at those under the microscope. There might be a reason that it might slow progression of these calcifications around joints and ligaments and things like that, but we have no proof of it at all.
Do you expect to, I guess maybe I don't know, forecasting here, but do you expect to, in the next 10 years, y'all expect to see maybe not a regression, but just like not a worsening of symptoms?
I think if we were able to slow progression of enthesopathy, that would be tremendous, and that would be really useful information, and that might actually alter when you decided to prescribe a drug in patients who were otherwise doing well and asymptomatic in their early 20s. If we knew that might be a bigger justification for that.
It's basically just a let's wait and see.
It's all we can do is sort of wait and see if that does it.
One additional comment, just that what I said when we were talking with Joanne, is there's going to be ongoing clinical trial called the XLH Disease Monitoring Program, in which these type of indices are going to be monitored going forward. So I think we'll be able to get the answer from that. It's just going to take some time to get the answer.
Do you guys foresee any problems or comments regarding somebody that has hyperparathyroid and using the new drug?
My opinion is maybe not. It sort of depends.
I guess when we looked at the PTH in the clinical trials, the PTH tended to go down in the people treated with burosumab. So I don't think it'll be an exacerbation, because I think that the PTH tends to go down.
Oh, I agree with that. I would agree that the PTH I don't think it's going to make the PTH worse. I think that we don't have complete proof. We have some suggestion that maybe the PTH decreases. However, what I'm more concerned about is if your calcium's already very high. Mm-hmm. In none of the clinical trials could you get into it if your baseline calcium was 10.8 or higher. And for some of them, the cutoff was there was a lower number than that was used for the cutoff. What I'm more concerned about is, for example, a patient of mine whose calcium was in the mid-11s, like 11.5, 11.7 range due to hyperparathyroidism in XLH. I'm actually a little worried about that spike in the calcitriol that the body does during those that first couple weeks after each injection, that might temporarily boost his calcium a little bit, and might he have problems with that. So I would be a little cautious if your calcium is very elevated.
It looks like an elevated PTH will drive bone turnover. I think I mentioned that obliquely yesterday. So I think it may undercut some of the efficacy of burosumab in terms of the effects at the level of bone. So I think it does depend on the degree of hyperparathyroidism, certainly if it's causing hypercalcemia, that's not, in my mind, tolerable. You need to at least normalize the serum calcium. Even if you use a drug like Sensipar to lower the serum calcium, the problem is it may not affect the actions of parathyroid hormone on bone. So to my mind, there's two questions. One is the one that Eric raised about the effects on calcium on 125, but the other is that it drives effects in bone. It makes the bone build up and break down too fast. And that is probably not a great thing to be happening in already diseased bone. So it's sort of a judgment call as to what level of hyperparathyroidism you start to get nervous about.
So we have a 5-year-old who has XLH, and he's been on burosumab for a year and a half. But he also has a Chiari malformation. And so I was wondering if you knew anything about what sort of weird overlapping effects we might have to look out for. Because one's skeletal and one is affecting the skeleton, I was wondering if there's stuff I should look out for. And his neurosurgeon is awesome, and we get an MRI every year. He's not an XLH expert, so anything you could add would be great. Thank you.
This is a great question, and it brings to fore even the whole question as to why this malformation occurs. There's some old data that just surveyed a random population of adults with XLH that were mildly symptomatic and some of them asymptomatic, and almost half had the Chiari-1 malformation in an adult population. This malformation has to do with the way the cranial bones are formed. At very low incidences, see evidence of some of these cranial malformations, sometimes even requiring neurosurgical intervention in the first year or two of life, at a low frequency, probably less than 10%. There's a risk for this. It's probably not based on the phosphate level, because some of these events occur right at birth, and we know the fetus, as was said earlier, is got normal blood phosphate levels. The baby's protected from the phosphate part of this whole story. But whether this FGF story or other problems, like related to the FEX problem, play some role in the way the different plates of the skull bones all come together in development, probably sets up this whole problem. And my suspicion is that the course of it is probably going to run independently of controlling the phosphate levels. It does raise the question of whether inhibition of FGF23 on non-phosphate effects could potentially play some role in how that develops. But I think that is probably something that's going to get back to this theme of the earlier the better with treatment, because I think these are generally things that get started in their development really, really early. But the real answer is going to be in these long-term studies and follow-up. Nice question.
But we also wanted to let you know that the network is here for you. So don't feel like you have to remember everything and then go home and act on it. We're here, so we're to be a support for you. So if you need, you just have more questions, submit them to us, and we'll be sure that it gets to the right person and we can get your questions answered. But also, I've heard from a lot of different people who are saying, we need doctors in our area. How do we find a doctor who knows anything about XLH? Well, we have a doctor database with the network. So you can contact us Our email addresses are on our website, xlhnetwork.org. You can email me. I would just do executive director at xlhnetwork.org, because if you try to do my other email and you misspell my name, you won't get it to me. But we're there to give you that information. So tell us where you live, and we'll give you the doctors that are close to you in your area.